I think we're running a little bit late, but we're going to make up for it with all kinds of high quality time spent together. I'm Susan Winter, and I'm, as you can see, co-moderator of this this panel with Wendy, Yun-Kyung, Magali, and Dejwan. And it's an interesting panel because it is quite interdisciplinary. This is quite a breadth of people that we have up here, which caused us to think about, well, why? When we're addressing the issue of health technology and the impact on communities, why such a broad panel? I actually come from the College of Information Studies, and most people don't know what that is. And actually that's the major question in our field, is what actually is a College of Information Studies? So you're not alone. Those of us in it also have that question. We basically look at issues at the confluence of information, technology, and people. And part of what we know is that technology leads. You get a new technology that shows up, and work practices and institutions then adapt to them. So there's kind of a leading, lagging function. But then as the institutions change, the technology changes. So it's really an issue of coevolution. In our area, historically, many of us started as colleges of library studies because it used to be that information and technology was very scarce and very expensive. And we needed special institutions to collect them, to manage it, to make it available. We called these libraries, archives, museums, hospitals, the Center for Disease Control, the State Department of Public Health. It turns out information and technology have escaped into the wild. Now it's everywhere. Everybody's got technologies that were unforeseen in the 1950s. The amount of information that's out there is just phenomenal. And so this leads us to an important challenge. Now that information and technology has escaped into the wild, we have to follow. We have to go where the people are. We have to go where the technology is. We have to go where the information is. And the fact is, we don't know what this means. We know that this is something that we have to do, but we don't actually know what it means to do technology-enabled health in communities. And so that's what this panel is here about today, is figuring out what are the open questions. What information are we dealing with? What technologies are we dealing with? What people are we dealing with? What kinds of communities are we dealing with? And how do we actually move forward in what is a rapidly evolving area? And so a few words from Wendy, and then we'll hear from our panelists.
Thank you, Susan. So clearly we bring different perspectives, and my perspective is more from a public health services research angle. For us, it is outstanding how since in the last decade, we've seen so many new technologies being launched into the market, but more importantly, all those technologies have been widely accepted and used by the public at large. When you think about it, it was only in 2004 when the first smartphone was launched. And since then, what we've seen is an array of devices and platforms that now are ubiquitously used and are not only also used by users of all ages, all beliefs, all backgrounds. In parallel to the use of devices, we've also seen the surge of social media platforms. So, for example, Facebook, YouTube, Instagram, Twitter. And what's interesting about these platforms is that they not only allowed users to create and upload their own content, but they also allowed users to share their personal data. And that has created a shift in the way that we think not only about our own information, but also about our own health and how we share it with others. So some would argue that the next wave is already here, which some have labeled as the Internet of Things, meaning devices that can connect with each other without human intervention. And this clearly is raising a lot of questions about how is it that we're going to be accessing health data, and how are we going to manage our own health data? How is it that we're going to share it with providers? How do we share it with others? How do we create what is now being labeled the health experience? So definitely we are now in an era that has been labeled as digital health. And digital health includes not only the use of technologies, but also how we use them for healthcare, for health informatics, for health education, for health promotion, and of course, for public health. So as increasingly sophisticated technologies offer promising ways to address critical issues in healthcare, such as access and quality of care, on the other hand, we have technological advances that they're not by themselves enough, and in order to be able to understand how we can not only leverage these technologies to truly improve healthcare, we need very strong collaborations between different stakeholders, which clearly include communities, but also include health systems, researchers, governments, and so on. This is why for today's discussion, we have a very diverse panel of experts that will each tell you a little bit about their own experience using health technologies and their perspectives on how they impact community health. So today in our panel, we have Dr. Young-Kyung Choi, who is Assistant Professor at the University of Maryland College of Information, College Park. Magali Rodriguez de Bittner, Executive Director and Professor of the University of Maryland, at the University of Maryland School of Pharmacy within the Department of Pharmacy Practice and Science, and Dewan Patterson, who is Senior Consultant of the Be More Group and Community Partner within the Patients Program. We hope to have a lively discussion, and so for the structure of the panel, each panelist will have 5 minutes to do a very brief presentation on their perspectives, after which we will have 15 to 20 minutes of moderated discussion. Then we will jump into an activity in which we hope to engage everybody in the audience, and we will then open the floor for questions from the audience. So we welcome all of you, and please give a warm welcome to all our panelists.
Hello. I am a human-computer interaction researcher interested in using personal data to empower people. I design data collection tool, visualization, and feedback to help people gain insights from their own personal data. And I do this work in the context of health, enhancing people's health and well-being. Suppose you have IBS or irritable bowel syndrome, and your doctor doesn't know what triggers it. So what can you do? You can start tracking your data, such as your food and symptoms, trying to make sense of the data to better understand your disease. And this is an example of self-monitoring. Consider Alex, who is a health researcher aiming to understand what factors aggravate paranoia patients' symptoms, especially in the public space. And he's trying to answer this question by integrating different in situ data collected in the field. While these two contexts are very different, they share many commonalities from the data collection point of view, and how to support them is the subject to my research. In the past, self-monitoring has been employed mainly for disease management purposes, and it was the clinician who initiated the tracking. But nowadays, the purpose has been broadened, and people collect their data for curiosity, to manage their health and well-being, and for fun, so we call them quantified self. In my work, I learned that there are many different people who have different tracking needs, and existing tools are not flexible enough to help people collect what's most important for them. So here's an example of iOS Health. And when it first came out, they missed one of the most important things that people track, which is the menstrual tracking. And when something like this happens, people are bounded by the initial design of the tool. They cannot extend or modify the tool, and they cannot collect what they want to collect. So my approach to address these challenges is to facilitate personalized tracking experience. So here's an example of a sleep tracking tool that I designed and developed. And here, there are some common elements that people track, such as sleep duration and sleep quality, but we enable people to customize factors that impact their sleep quality, such as caffeine for those who drink coffee, or smoking behavior for those who smoke, and etc. And pushing this idea further, we enabled people to construct their own trackers composed of different building blocks of data for different people. So to create this kind of flexible tracker, we combined the different data sources, both from manual journaling, and we integrated automated data from external sensing and wearable tools. So we designed and developed OmniTrack, which is a mobile platform that enables people to construct their own trackers without programming. With OmniTrack, people can create a variety of trackers, from breakfast trackers to smoking log, all exclusively on the mobile devices, and this kind of work shows really the power of customizable tracking. In the clinical context, clinicians can also leverage customizable tracking. For example, in the context of food tracking, depending on whether you have diabetes or eating disorder, your tracking needs are different, and the tools should be different as well. So this is a tracker that one of our dietitian participants created for her patient who has eating disorder, and see how different and expressive this tracker is compared to a generic paper-based food tracking. And lastly, customizable tracker can also benefit the researchers. Usually, it takes several months to build a tracking tool for research purposes and develop it and deploy them. But we are extending OmniTrack system so that researchers can use this system to create a tracker for research purposes within several hours. And people from other research labs have been using this tool to collect research data. So here I will leave with these parting thoughts. Imagine anyone can design a customizable tracking tool without programming for their own tracking needs. And it's not the company who owns the data, but they own the data and they have readily access to their data. And imagine clinicians can prescribe a tracker as if they are prescribing a medication, and imagine how this kind of tool can be used for shared decision-making purposes. And lastly, researchers can leverage this tool to collect data from individuals to better understand the population level. And altogether, our goal is to empower people with their own personal data. Thank you.
Well, good morning, buenos dias. You heard through the introduction and also with the last speaker, all the advances that we have had in technologies, all right? We hear that people can track their sleep, they can track their medications, they can track anything that they do. So what I wanted to do today, very briefly in my 5 minutes, give you a quick overview of what can we do from the clinical perspective with that data, all right? What can we do to take all of that information that is out there and use it to really customize individualized care for the patients in a way that is effective, and also do it in a way that we meet the patient's needs. And what I mean by that is meeting the patients where they are. Is that right? So we have all of this technology, and in spite of that, I still believe healthcare we're way behind in meeting the needs of our patients, and we still have people that have to go to doctor's appointments, have to go find a parking, get out of the parking, go to the physician, sit there for 3 minutes, do the same thing all over again, especially individuals that may have difficulty in transportation or other health issues. We also know that medications are a critical issue in healthcare. We know, and I like to show this because it's really critical that we keep in mind that for every dollar that we spend in giving individuals medications, we spend about $3 treating the side effects and the complication of inappropriate drug use. So this is a healthcare crisis and also a public healthcare crisis. So with that in mind, what we did is we, at the School of Pharmacy, put together a variety of clinical programs to test this whole concept. How can we do two things? One is leverage technology, but number two, put the pharmacists in a case management team, making them work in an interprofessional way, but also do it in a way that is patient-centric. So instead of doing the same approach, the same program for everyone, can we customize by leveraging technology and also leveraging the needs of our patients? So the programs that you're going to see are really centered in this model, which is, again, case management, interprofessional, but really taking into account how can we optimize technology and interprofessional approach. So we have a center at the school where we have students, faculty, staff, where we actually contract with a variety of health entities to develop programs where we manage and provide clinical care to patients throughout Maryland. In this particular center, again, what we're doing is maximizing the availability of data, patient data, but also electronic health records. So we have access to electronic health records, both in the physician's office, but also in the inpatient setting to get the appropriate data that we need to manage those patients. So what kind of programs have we been able to establish? So the first one that I wanted to briefly mention to you is what we call an interprofessional transitional care program. This program is, again, think about what's happening to individuals that get admitted to the hospital. They go home, all right? They get to their home, and then they're all confused and they have no assistance of help when they get home. So what we do is we actually, through the center, do a 24, 48-hour call, do what we call a medication review, medication reconciliation, make sure that the meds that the patient had at home are what they're supposed to take, the ones that they got in the hospital, educate and orient the patients. And then for those patients that have accessibility to smart devices, we could do this using a smart device. Simple, they don't need any equipment in your iPhone, FaceTime, in your computer, in your tablet. Any device that you have at home, the pharmacist actually can come to you. We come to you. No need to transport that individual that just left the hospital and is tired and sick. Family members don't have to take off to take that particular individual to an appointment. So everything is done to meet the needs of the patient while they're there. And then by completing a medication list that then is shared with the primary care provider and then is input in the electronic health record so it's available to everyone. The second one that we have is more specific to a disease state, and this we're doing in the Eastern Shore. Again, accessibility to healthcare providers is an issue in the Eastern Shore. They may not have access to all of these providers, specialists. And then we also do the same working in a physician's office, but we also go to the patient's homes. So patients come for the first visit to the physician's office. We do the telehealth visit, and then we lend them tablets that the patients take home, and we do all the monitoring and follow-up. Imagine somebody using an inhaler, and through the video, they show us how they're using it, and we can coach them. We can counsel them in how to do that and track their questions and medication use. And then the last one is a project that we're doing in West Baltimore. Again, a community that has great needs, a lot of social determinants of health. So we have partnered with the fire department, and the fire department has a team of a nurse practitioner and a paramedic that actually goes to the patient's homes. While they're in the home conducting the home visit, we at the Telehealth Center have the pharmacist interact with that patient and conduct the visit while they're there. So again, briefly, I just wanted to show you 3 different programs that we do, all of them leveraging 3 things, the right technology, leveraging patient-centered care, and leveraging meeting the needs of the patients where they are. Again, what we do is we take data from a variety of sources, we develop a targeted intervention, we deliver care, and then we evaluate the outcomes and we see how are we improving the health of that patient and the health of that community at large. And this could be replicated for any disease state, diabetes, hypertension, you name it. Any program that we want to improve the health, and again, using all the technology that is available. And again, the challenge continues to be how do we take all of these, integrate it, how we develop virtual teams of healthcare providers that meets the needs of the patients, again, advancing the use of technology.
Good morning, everyone. Once again, my name is DeJuan Patterson, and give another round of applause for my colleagues that stood before me. Thank you. Now, I'm here, and I will speak a little bit more on as technology will impact from a community perspective. I'm a consultant with the BMO Group, and I partner up with the University of Maryland School of Pharmacy, the Patients Program. And we sometimes leave out vulnerable populations who do not have as much access to digital devices and access. So when that comes to play, we tend to develop a relationship based on high touch. We got to do high touch and high technology. Inside this hyper engagement environment, we rely on this new approach where we phrase this as ACEs. ACE. The approach has to be actionable, connected, and expendable. So with these type of things, with using a social media platform, you make sure that your acts is actionable. And you are relying on trusted communicators within a community that suffers from a digital divide. Within the Patients Program, we see that key communicators or influencers in Baltimore and West Baltimore will allow you access to community and allow the community to have an authentic relationship where it's mutually beneficial across the board. Once you have mutually beneficial relationships, you're allowed to extract information that's valuable to both parts. You make the community healthier because now the community is actually taking part in their healthcare research and their treatment plans. As far as the researchers and practitioners, now they have access to vulnerable communities who traditionally have a certain level of institutional mistrust that have been developing through a course of time because of sometimes of institutional racism and a lack of access to information in some communities. One thing that we learned through this authentic relationship is that community also have skills. So when you identify key community partners, you're allowed to enhance your program's effectiveness, their reach, and their approaches. Taking my own self in that example, coming from Baltimore, Maryland, I had key social capital and not only skills with social media and strategic communication that not only expanded in Baltimore, West Baltimore, but across the nation. So you're leveraging those skills to give credibility with some of our stakeholders as well as the practitioners to leverage and be able to translate information from a technical term, industry, to a more labelable terms inside the communities. So when we're talking about digital divide, we got to make sure that we are being inclusive of the people who we are trying to reach and making sure that that information is translatable when we do provide them with certain technology tools where, custom, a thing that we say about researchers, I'm a researcher as well, sometimes we tend to talk amongst ourselves about population that's outside the room. So once you include the population inside the conversation, they begin to help with the development, the implementation, and evaluation as it relates to patient-centered research is what primary as my focus. Once again, I reiterate ACE, which is action, connectedness, and that connectedness may help you be able to connect with people who go beyond your education, your communication barriers, and lived in life experience. An extension is also something where as though it can be duplicated across the board. Where I leave with one example where everyone heard about the Giving Tuesday example. This organization is 150 years old, and it was coming up on this hyper technology engagement where you had Black Friday, then you had Cyber Monday. So they came up with Giving Tuesday. And Giving Tuesday was such a success because it was action. People had the ability to give. It was connection, so they can connect across, they can connect across the board, and they're expendable, because now that different people can adopt and connect with that in such a way. So now is erasing a centralized authority, but more so decentralized, so everybody can adapt and make that a beneficial way to engage. I'd like to hear more from the panel. Thank you.
Okay, so great. After these wonderful presentations, we are now going to the guided discussion, or start the guided discussion. And maybe one of the first questions for the panelists would be, which would you say are some of the critical challenges that you have faced in your work in relation to the implementation of technology and how communities accept or use this technology for health purposes?
You want me to start? Is this on? I think we have confronted two main challenges. One is, again, changing the culture of some of the healthcare institutions we're working with to introduce these tools. Again, I think there's still a very ingrained way to deliver care that people think this is the way it has to be. And so when you bring these innovations and a different way to do it, I think you confront some challenges with changing the culture. The second thing is we have confronted some issue with technology, and the one said it really well, that while it is true that if you think about how many of your grandparents have smartphones and use FaceTime? All right? So we all assume everybody does, all right? And we said, oh, that's pervasive, everybody uses. But what we found in one of the communities that we were working with in Prince George's County is that while the patients had a phone, they did not have a smartphone, all right? The phones that many of our Medicaid provides, or some of our government assistance is not a smart technology. So what we thought, oh, everybody has it, there's still some populations that don't have access to those devices. So you need to develop ways to go around it, and that's why we purchased some tablets and some devices to be able to lend it to the patients that we were serving. So I think for us, Wendy, those were like two of the things. But, you know, I was really surprised how well the patients accepted it. Like, we thought that patients, again, you're changing culture, you're doing disruptive innovation, and we thought the patients didn't want it. They just wanted the traditional coming and seeing you in the clinic. But the patients, even those that, you know, Medicare patients, were very accepting of the technology.
And that's definitely is one of the considerations. I think for a while in the field, the debate has been whether we have several generations that have different comfort levels with technology, and I think that is actually changing. Our assumptions that older adults don't use technology or are highly challenged by it, or the assumption that all generation, I don't even know what generation it is, but all the generation that was born after 2000 is technology native. I think we have to start also being more flexible about those assumptions, and until we go into the community, talk to them, if the community sees the benefits for the use, they're more likely to become engaged, and maybe, yes, go through a learning curve, but will also likely to adopt the technology.
I have two main challenges that I see in health technology. The first one is the development side of the health technologies. So a lot of technologies that we are using for health purposes, those are wearable sensing, mobile apps, and smartphones. They are largely driven by the companies, and we don't necessarily have strong input in their direction. So for example, Fitbit or Microsoft Band, if it doesn't make money, they will discontinue it suddenly. And if your research program is largely dependent on those existing technologies and suddenly it's not accessible, then you're in a problem. So that's one thing that I see, including it's not just the devices, but the data itself. So if you track your data using Fitbit or you collect your data using any mobile phones, the data is stored somewhere in the cloud, owned by Google or Amazon or Microsoft or other companies. The second challenge that I see is the privacy side. In the context of health technologies, there's a huge difference between self-tracking and tracking, or self-monitoring versus monitoring. So if you're adopting Fitbit to self-monitor your data, that's great because it increases your awareness. You can be motivated by looking at the data and explore your data. But if a company or your employer is using Fitbit, making you use Fitbit for one of those employment benefit program, then it's really unclear who has access to the data, how they use the data, whether the third party has access to the data. And even though you are contributing and collecting your data, you don't have control over your data. That's one other concern that I have in working with health technologies.
Yeah, those are very important challenges, and I actually have an additional follow-up question based on your presentation. So you mentioned that through your platform, users have access and not only control about what they collect, but also access to their own information. Are you envisioning like the creation of larger communities of users who then can share their data with each other? Is that something that you envision through your work?
Not at the moment, but definitely that's the direction that I am heading toward. So right now, individuals who are contributing to collecting their own data, they are the only ones who have access to the data, plus researchers. That would be me and my team member. But if other research team is using OmniTrack, I don't have access to their data, so I can control that. But the future direction that I'm thinking is how to support collaborative tracking, because tracking is hard. You need a huge motivation, and there's gotta be a fun way to do this, and social aspect is a huge motivator. So how to properly support the social aspect of tracking together so that you have accountability with each other. So for example, older adults who track themselves with their walking buddies, or it can be parents with their children, or it can be many different contexts, but how to support those collaborative tracking is definitely something that I want to explore.
If I may, my colleagues mentioned 2 points that's really relevant, and I want to make sure I amplify some of the challenges that we may face. Just the historical nature of some of the vulnerable communities' relationship with healthcare providers, research institutions that develop a level of mistrust that was passed down historically through generations. So the challenge could be of viewing this innovation of healthcare tools as invasive and a continual level of mistrust without the proper level of education and supporters. And then the next challenge will be a communication challenge. Sometimes we think that communication is very simple because we're accustomed to industry technical terms. However, we rarely ever think about how does the community translate those terms? How do they understand those terms as it relates to their community experience, culture? So having that level of intel to be able to be understanding and educating, and having different stakeholders being involved in the design of healthcare innovative tools is really helpful, because now you help to alleviate some of those communication challenges.
Excellent. So I guess to follow up on on this conversation, something that as we were building the panel came up was whether as health providers or members of a health system or even researchers or government agencies, how have we been able to keep up with the fast pace of technology? So I think an important issue also to discuss is whether whether healthcare in general, and I would add to that public health, has been able to adapt to technology, and which ones do you see are some of the limitations that either healthcare or public health is facing in terms of keeping up with the fast pace at which technology is changing?
I think that from the healthcare system perspective, and at least from our perspective, is cost. These things change so quickly, and they are very expensive to get licensing. So it is, I mean, by the minute we do a contract with a software company, they change, they're bought by somebody else, terms change, and it's a very difficult to keep up because it changes. And again, if you're doing clinical care, who pays for that? Is it the patient? Do you do it as part of, is it the health plan? Is it the health system? Is it the government? So it becomes a little bit challenging in that perspective.
I totally agree on the cost side. So again, relying on these external devices or even developing in-house tools, it costs a huge amount of money. I encourage public health researchers to think about teaming up with us, people at the information school or people at the computer science, so that each parties can make progress from their own perspective. Well, that said, we are not developers, but you have to approach your partner in a conscious way, so that thinking about how we can, both parties can develop our own research agenda while collaborating on a meaningful project. That said, I am trying to open source a lot of work that we are doing in my lab, although that itself has a lot of challenges. But yeah, I think open source licensing is one way to lower the cost, especially the things that we develop in-house. So I totally agree with the cost side.
Well, and I guess with open source, you also have the possibility of others contributing to the development of technology.
Yes.
Correct.
Although creating the ecosystem from scratch is very, very challenging, but that's why I'm here talking about our work and then inviting others to contribute.
Ecosystem. Susan, do you have any questions?
So I guess, what kinds of communities do you include as you're designing these technologies and these systems and these interventions? What are the ways that they get included? So tell me a little bit more about sort of the steps you take to have the dialogue that actually leads to this more appropriate, personalized type of use of technology in the health context.
Yeah, I'll start with. And in Baltimore with the Patients Program, we start by identifying key influencers and stakeholders within the community. And once we build a rapport and relationship with some of those key stakeholders, we actually listen and understand what are some of their priorities and their interests. And once we have that level of understanding how this could be a mutually beneficial relationship, we develop that into a bi-directional exchange. And then we expand from on that to where we incorporate it from the design phase of it all the way down to the evaluation. So you're a part of the process every step of the way. So you see yourself, you see your ideas, and you see your community being a part of the design of these community health tools.
In our clinical programs, it's mostly done by surveys that patients get, satisfaction surveys, and so they're asked for alternative ways, and so sometimes they do provide that information. And for some of the projects that we design, we have done some focus groups. So getting individuals that, for example, the project that we had in Prince George's County, one of the things we saw is that even though we provided the clinic, it was an interprofessional clinic, it cost, it didn't cost any co-pays to the patients didn't show up. So we tried to do a focus group to ask them what is going on. And part of what we identified is transportation, big issue. Even if we were offering them Uber to come, they still didn't come, even if the car went in front. So we kept digging deeper, and what we found is just the comfort of home. And the desire of the patient not to leave home and to receive the care there. So
I'm coming from a field called Human-Computer Interaction, where there are a set of methodologies to involve users, our stakeholders, in the process of design to evaluation. Some particular method that I use are, of course, interviews and surveys, that there are things like co-design methods or participatory design, where we invite people in the design process, and we give them prompts to think about design and lower the barrier to design new technologies. That said, the most difficult challenge in the process is recruiting. So for example, it took us 3 to 4 months to recruit 6 dietitians for the project that I briefly introduced. That's the kind of challenge that we are facing.
So you've all discussed or talked about the experiences in your projects in terms of disseminating your programs or your interventions. But possibly many people in the audience are maybe thinking of using health technologies for their own work, or maybe even to track their own health. So if you were to share some of the lessons learned from the work that you've done in terms of not only engaging the community, but also engaging them in the use and access of these health technologies, which would be the lessons learned that you would like to share with the audience today?
I guess I will start. I would say beyond some of the tips I recommended, making sure that the users are part of the process thoroughly, from design to evaluation, but also stay committed, revisit those stakeholders who you had solicited for support, whether it's from design to evaluation. Staying committed and connected with the stakeholders help you to be able to update and identify different kinks of best practices and how people are still ongoing using the support of that program. The next thing is share your stories. Share your stories and have the community be involved. One of the things that we're using adamantly is social media and different ways of how the community has benefited for being a part of the program and developing the tools. So being able to have people involved, and also making sure people are empowered once you no longer are taking part in that aspect of the program.
I would say broaden your stakeholder groups. For example, let's say you're designing a tool for patients. Of course, you have to involve patients in the design process, but you also need to involve other stakeholders, such as like clinicians who are treating them, or other caregivers, informal caregivers who are working with the patients. So you have to broaden the user group, and then, of course, include them in the design process early on. And vice versa, if you're designing a tool for clinicians, think broadly who are considered as clinicians.
I would say, kind of echoing with the one said about patient input, making sure that whatever you design, that you get the input of the patient, because sometimes we design these wonderful things, right? And at the end of the day, the patients don't like it, don't want to participate. The second thing is do your homework with interoperability and how you're going to integrate all of these systems and data. That is a very big issue about, what data can you pull in? Does it have to be, manually extracted? So we had, just to give you an idea, in our project, we're working with 3 different electronic health records. And then we're working with some physicians' offices, and we have about 6 different electronic health records that are using, all requiring permission to access, all requiring training. So it's really very tedious to do that. And then I think the last thing is always have sustainability in mind. Anything I do, I always try to do a business plan, because a lot of these become pilots and never go anywhere. So as you're doing these projects, always keep in mind, how can I replicate this? How can I make this sustainable?
Can I add one more thing?
Of course.
So in the research context, it's so easy to see your participants as subjects, and you want to learn from them, and then when the research is over, then that's it. But I encourage you to think about what you can give back to the research participants. In our field, we rarely use the word subjects, but we use the words participants. And even in designing a tool, for example, and trying to get input from people, I tend to follow up with them when we are done with the designing of the tool, make sure if they want to access the tool. If so, then I provide them. And if you're designing a tool for data collection purposes, think about what kind of data you can include without threatening the validity of your research project, but still help people who are contributing to the data, what that might be. So, give back to the participants.
I have one last point to make. I was sitting here thinking, and I'd be remiss if I did not bring up this point. Rules to maintaining sustainable, trustworthy relationships. Be mindful and equitable in maintaining, whether it's compensation, authority, or recognition. And when you see your participants more so as partners, when you're dealing with the end users, making sure that you're equitable in the distribution of its compensation, authority, or recognition, because that will help to maintain integrity, commitment, and trust with the target, with the population of community that you're working with. So always keep that in mind, and we witnessed that throughout the design and phases of our doing the work that we're doing. Because sometimes you can have a participant being a part of the project design, but they don't have the authority to actually execute some of the things of best practices that they witnessed from their standpoint. So those 3 things is really important for best practices.
Okay, so hopefully through this first part of the panel, some ideas and some questions have sparked in the audience. We're going to do a very small activity just to spark some more ideas, and then we're going to open the floor for some questions. So, okay, let's see. Okay, so for this activity, please, everybody participate. It's very simple. I will be showing everybody a series of questions, and what I would like you to do is to think about which one of the answers applies most to you, and then we will do a short poll to see what the audience feels in terms of these questions. So the first one is, which is the best way communities can use technologies to improve their health? And we have 4 options. The first one is to learn about strategies to improve their health, to connect with others who share similar experiences in their health journey, to access and use health services, or to connect with resources outside of their community. So, if you had to choose the best, who would choose number 1? Okay, so a few people, don't be shy. Take this time to stretch. Excellent. Who would choose number 2? To connect. Okay, so more people think this is a way of connecting with others. Number 3, to access and use health services. Excellent. So a lot of people feel that this is just a good way to get in contact with the health system. And 4th, to connect with resources outside of their community. Okay, excellent. Okay, so there's not any right or wrong answer. It's really to get a feel of what are your perceptions around community and connectedness. Now, out of curiosity, how many people in the room are researchers? Okay, a few. How many are providers, clinical providers, or are in the clinical health setting? Okay, so a few as well. And how many are not either researchers or providers, but come from other perspectives? Excellent. So we do have some diversity, although it seems that it's heavily leaned towards providers, which would explain number 3. Excellent. So to the next question. Which communities are you a member of? And for this one, you can choose more than one. So online users of health platform. How many of you are users of an online health platform? Okay, number 2, you are a member of a virtual patient support group. Okay, we have a few people who have experience with this. You are a follower of health thought leaders or influencers in social media. Yeah, that's a quick one. And number 4, you are a supporter of YouTubers or bloggers. Excellent. Okay, so again, we have a very broad experiences in terms of defining or membership to different health communities or communities that provide health information. And the last one, which of the following are challenges to build trust with online communities? So again, the idea is to choose which one you think is one of the biggest challenges. So number 1, not being able to interact face-to-face with other members. 2, differences in language used to describe health experiences. 3, identifying trustworthy influencers or key communicators. And number 4, finding credible sources of information that present evidence in a balanced way. So who would say that number 1 is one of the biggest challenges to build trust with online communities? Okay, a couple of people. Who would say is number 2? Differences in language. Number 3, finding trustworthy influencers. And number 4, finding credible sources of information. So it seems that the audience is leaning towards issues around credibility, trustworthiness, and value of information, more so than the communication itself. Okay, so we have a very nice sense of what are the audience's perceptions on on a different way of thinking about communities. I think, especially coming from a public health perspective or from a health provider perspective, we typically think of communities as communities like in person or physical communities or neighborhoods. But the truth is that with the development of technology, we are also experiencing this other level of communities, which are the virtual or online communities. We're all exposed to them, use them in different ways. And they could be also powerful tools, not only to disseminate information, but also to access and use information around health. So with this in mind, we would like to open the floor for questions from the audience. So please feel free to walk.
There's a microphone up here.
Chris Williams, incoming doctoral student for community health.
Okay, then the other question is the microphone on? Because
it is.
I think so. Okay.
That's better.
My question is around the sort of big picture of healthcare, and the future is not just one, where there's like a lot of technology, but we might envision that the future of healthcare is potentially many different futures, where those who are technologically sort of in tune can take advantage of apps and other technology, whereas there could also be a future where we concentrate our resources on population health. Think of triple aim, for example, improve population health at lower cost and better quality. So I guess my question around this discussion with technology is, how do we build something to satisfy one of those futures while also taking into account the other futures? So potentially population health and value-based care. I was wondering how you consider those particular things and how you develop and execute your technology. Sorry, I know, loaded question.
You want me to take the value-based? So I think that you seeing it. I think you're seeing that in healthcare, they're starting to develop these pockets of innovations, all right? And you see many of the health plans and the health systems are trying to meet everybody's needs by providing a variety of ways for you to access care, all right? So you could either access care by going to the traditional way. You go to a place, a physical place, you see a doctor face-to-face. Others are incorporating all of this technology and telehealth. So now gaining access, there are some opportunities for you to have 24/7 access to a physician, all right? Either by a chat or either by using telehealth. So we're starting to see that these hybrid models are coming out there. So I think that, but what we're seeing is that I think in the future, as the generation of the individuals we're serving are demanding more technology. I mean, my kids, cannot understand how in this age you have to go a physical place, all right, to somebody to see you for 5 minutes. So we're starting to see that healthcare is evolving and changing. With value-based care, I'm working with 100 primary care practices in Maryland in a values care contract. And more we're seeing that technology, access to those patients, 24/7 access, being able to have access prior to somebody going to the emergency room, so you could treat the symptoms right at home, is really what it's all about, is reducing unnecessary healthcare costs.
I can be brief. So you're correct that a lot of existing technologies tend to benefit those who can afford them. But because of that, I think it's really important to train our kids in terms of health literacy early on, so that they can understand what it matters to understand their health, what it matters to manage their health, what are the things that they can do to manage their health as part of early curriculum. So even incorporating tracking, incorporating what steps mean, incorporating what blood pressure mean, and how to track those, how to manage those, not using expensive systems, but start using a very mundane tool such as pen and paper. I was really surprised to see this coming back of bullet journaling as a really powerful means to be aware of yourself, because that's a very fundamental way of tracking yourself, using pen and paper, trying to identify what's important. And then I think that can be part of the health literacy education as well.
Hi, I'm Marie Gmon from the University of Maryland School of Nursing. I wonder what obligations you all feel as kind of people forging ahead with health technologies in terms of social isolation, which is a major driver, behind so many public health issues. And I have heard the argument, and I don't discount it, that technology can connect people, but it connects people in a certain way and not in this way. And I'm looking at my colleague, Dr. Obulu, because I know this is her area of research. But I think it's a huge issue. And the hurdles that we can overcome by reaching people, if we have widespread smart technology to all those who need it are great, and they have definite benefits. But is there a technological way to meet that beyond the distance connection, but to really get at social isolation? And do you have any thoughts on that?
Well, given the emerging technology that we have, society that we have today, given to an earlier point I made, that we have to be intentional about taking a dual approach, having high technology and high touch. Because even though that we may increase technology and the access to technology, we know there are certain people, a population of people who are just do not have, and sometimes we have digital blackouts in certain areas. So to be able to have a high touch approach with identifying key influences that are not just key influences online, but within the community is really important. In the work that we do, we have those key influences within the community are on the ground, and it's connecting, and you channel the information from those technologies to people to help stay connected in a physical sense is really important to act as a bridge. So once again, I would always reiterate that we should have a dual approach and an understanding of high tech and high touch is really important as we progress forward in today's society.
What I would like to add is that it was a reflection that we were having just before the panel started, and is that technology has moved at such a fast pace that I think as a society we still haven't digested very well what it means and how we use it. But when we think about the generation of technology native youth that is coming, they have a different way of socializing that it's not something that, for example, I would think of. So if I'm with my friends, I would not be texting with them if I have them in front of me. But that's just a new way of socializing. Now, whether that changes, the way we relate, how we build relationships, of course it does, but I think we haven't reflected as a society what it means. I think in some instances, technology can certainly be a tool to feel some sense of connectedness, especially when there's significant isolation, maybe because of mobility, maybe because limitations in communication. And we've seen really good examples where tablets or eye recognition technologies are helping youth or other patients that are unable to speak to actually communicate. So I think we are just getting to the point where we're realizing that the way we connect with each other is going to change. We haven't engaged yet in those conversations at a social level, maybe at an informal level or casual level with our friends, but not necessarily as a society reflecting how this is changing our dynamics and what impact it's going to have. So it is a great point, and it's something that I think will have to happen as we move forward with newer technologies, for sure.
Hi, Portia Bushango. I'm a PhD student in Health Services Administration at the University of Maryland. So my question actually is about bringing in, how do we bring in community-based organizations into this discussion in terms of them being a source for data? We know many patients outside of the hospital interact with these organizations to get other services, whether it's transportation or other social services. And so how can those entities as a data source be useful and perhaps tie in terms of what you guys are trying to do in terms of collaboration?
Well, I would say making sure that you understand how your relationship can be mutually beneficial to the community, and going back to the point of seeing the community as partners and not just patients, because the community have assets that you could also benefit as well. Just giving a quick example, within Baltimore with the Patients Program, we have a community partner with Pastor Lance, Mount Lebanon Community Baptist Church. Huge asset within the community, access to the target population, the community you would like to do work with. And as a result of establishing a trustworthy, mutually beneficial relationship, Pastor Lance asked that the Patients Program meet the community where they are, and the Patients Program went into the community, did a health resource fair, and actually dance and understood and participate in whatever the cultural experiences of the community, and in exchange they was able to understand and leverage that relationship to better serve this community. So being intentional about your relationship, making sure that it's mutually beneficial, and it's bi-directional relationship but not one-sided. Community can be seen as, community should be seen as your partners and not just patients and subjects.
We've actually been told we have to wrap it up. This is such a great conversation, and our panelists will be here for a little while anyway, and you've got their names and contact information. So it sounds like we really hit an important topic. And my background is actually as an organizational and systems scientist, and so as I listen to the issues of complexity and opportunity here, I'm reminded of an article written by Charles Lindblom in 1959 in Public Administration Review, which has 13,461 citations. It's called The Science of Muddling Through. And he said, you know, you do some things and you see how it works, and then you try some other stuff, and some things work and some things don't work, and you keep making little adjustments. The fact is, we built the internet, we built these technologies. We never could have sat down and planned and designed these technologies. We never could have sat down and planned the internet. It had to evolve, it had to emerge with all of its negatives and positives. We never sat down and designed a health experience system for the 1950s. It evolved and it emerged. We are not prisoners to what we've developed in the past. Charles Lindblom had a follow-up 20 years later, 1979. The article was called Still Muddling, Not Yet Through. We are not captive to what's we inherited from the 50s, but we have to respect that there is a historical trajectory, developmental trajectory, but that we have the power and we have the ability to design the future health information, health experience system that we want to have and that we want to live in. Part of what we need to do, as I heard over and over again, is partnerships and thinking about the complexity of people's health experience all the way down to the infrastructure of, do they have the connectivity, do they have access, do they have the culture that actually encourages or discourages this kind of behavior. So I thank our panelists for being here and bringing the multiple perspectives. And I trust this is the beginning of the conversation, not the end of it.
Well, thank you, and thank you to the co-moderators.